Okay, in this video I'm going to talk about the shoulder complex. I'm not going to talk about every aspect of it. I'm just going to cover some key concepts and principles. So the shoulder is a really important joint. It's one of the most mobile joints in the body. And the reason for that is what is the purpose of the shoulder? It's really to place the hand in space. And if you think about what makes us human from a physical perspective, it's really what we do through our hands, eating, feeding, making tools, that kind of thing. And if you can't place your hand where it needs to go, you can't do any of that. And even if your hands are perfectly fine, if your shoulders are not functional, you're not really functional. So the shoulders are really a very important joint. Like I said, it's one of the most mobile joints, and it's also one of the most complicated joints. All the joints in the body, the purpose of a joint is to provide both mobility and stability. And that's kind of a paradox, right? Because if you're going to have more of one, you're going to have less than the other. And as we go through the body throughout the year, each joint kind of solves that problem in its own kind of way. The shoulder, for the most part, is not a very stable joint. It's really a very mobile joint. And what I'm going to talk about now is some of the ways that it gets its stability, which again is quite different. But the first thing to think about is how it's not really a very stable joint. So the other thing to remember is that when people say the shoulder, they usually think of this, right? They usually think of what we call the glenohumeral joint, so where the scapula and the humerus meet. But in fact, this is only part of the shoulder, and typically people will Newman uses the term shoulder complex because really the shoulder is actually 4 joints. It's the glenohumeral joint, it's what's called the acromioclavicular joint, okay, and that's here, that's going to be the distal end of the clavicle meeting the acromion of the scapula, okay? And then it's also the SC joint, the sternoclavicular joint, and that's going to be this proximal end of the clavicle, meaning the sternum. That's going to be over here. And people will also talk about what they call the scapulothoracic joint, and that just refers to the scapula lying on top of the thorax. Now the important thing about the scapulothoracic joint, it is not a true joint, okay? So the glenohumeral joint, the AC joint, the SC joint, those are synovial joints in the way that we described. The scapulothoracic joint just describes the articulation of the scapula on the thorax. It just lays on the thorax. It doesn't have a synovial capsule or any of that stuff, okay? But because the scapula is so important, and because sometimes there are things that come up in that spot, people will talk about a scapulothoracic joint. But again, it is not a synovial joint, okay? So all of those, that position of the scapula and these 3 joints all work together to create shoulder movement. And although the majority of the movement is between the scapula and the humerus, if you don't have the right movements at the AC joint, you will not have a normal shoulder. And in fact, a lot of treatment for shoulder dysfunction doesn't really have anything to do with this articulation. It has to do with what's going on over here, okay? And that's what we're going to kind of get into now. So again, you have the SC joint, which is the articulation between the medial part of the clavicle and the sternum. This is actually a very stable joint. It has a disc and very strong ligamental structure. You don't hear about dislocation here more. What you hear about more, right, is a collarbone fracture. Collarbone is kind of a layperson's term for clavicle. So this connection here is so strong that the bone will break before the ligament will give, okay? So the SC joint, very stable joint, that's over here. The AC joint is over here. It's also quite a stable joint. Sometimes it's vulnerable to trauma, so somebody directly hitting it. Otherwise, it tends to be pretty stable. Has a lot of ligaments to stabilize it. Going back to the SC joint, at the SC joint, you have several movements. You have protraction and retraction, elevation and depression, and what's called a posterior spin, so a bit of rotation. You have all 3 movements there at the SC joint. At the AC joint, we talk about elevation and depression, okay? And then they talk about what are called sagittal and horizontal plane adjustments. So it moves in all 3 planes, but in the sagittal plane and the horizontal plane, those movements are kind of so small, and because the surfaces are really flat, we don't really describe them any farther than that. We just talk about adjustments. So both of these joints are going to move in all 3 planes, okay? And then you have the glenohumeral joint. At the glenohumeral joint, you have abduction, flexion, extension, and rotation. So it's has all 3 degrees of freedom. So all 3 of these joints have all 3 degrees of freedom. So all 3 of these joints have to work together. So getting to the glenohumeral joint, that's the articulation of the humerus and what we call the glenoid fossa of the scapula. And looking at it, there's a couple things that you should notice. So joints in general are going to get their stability sometimes through the fit of the bones, what we call a good bony fit. They also can have very strong ligaments. So I already alluded to the fact that the SC joint, especially, and the AC joint have pretty tight ligamentous structures. They have quite a few ligaments. They're held on pretty tight. At the glenohumeral joint, there are ligaments. They're not nearly as tight. Okay, they're there. They definitely provide support, and if they get injured, that definitely causes a problem. But they're not nearly as tough as the ones here. Okay. The other thing you should notice is looking at the head of the humerus and looking at the glenoid fossa. That is not much of a fit. Okay, the head of the humerus is quite a bit larger than the glenoid fossa. Okay, and the joint cavity in general of the glenohumeral joint is kind of big, which from a stability perspective is not really what you might want. Okay, because there's a lot of room for the humeral head to move, and that can cause problems when it moves when it's not supposed to. So unlike a lot of other joints, the glenohumeral joint does not have a good bony fit, and it doesn't have a very strong ligamentous structure. Okay, so it's kind of fundamentally not a very stable joint. Okay, it gets its stability through muscle control, okay, and through position of the scapula primarily. So what do I mean by that? Well, if you look at just how the scapula is normally positioned, okay, this is sort of a neutral position of the scapula, you'll notice that you have a bit of an angle here at the glenoid fossa, okay, and the humeral head will actually kind of sit on that glenoid fossa, kind of like a shelf, right? So that's a passive way, almost, that head can fit, that the humeral head can rest onto the scapula. So technically, for this part, you don't have to actively hold your humeral head into that glenoid fossa, okay? If, and this is the big if the scapula is positioned properly. This is basically kind of a neutral position. But for some reason, if that scapula is not positioned that way, let's say it's tilted a little bit, now what's happened? Now you've lost your shelf, okay? So now this humeral head could actually dislocate, or sublux is a term that you'll hear, which doesn't usually happen normally, but it definitely can be a source of dysfunction if you have this position and this humeral head has to be actively supported now. And not only that, but the ligaments are, ligaments don't really, they are set up a certain way, and they're going to provide maximum tension and support in this position, not in this position. So you're setting yourself up for more instability, okay? So that's what can happen if the scapula is not properly positioned. I'm not going to talk about muscles in this video, but the scapula, position of the scapula is completely dependent on muscle control. Okay, there's a little soft tissue that holds it on, but for the most part, and we'll talk about what we call scapular stabilizers, muscles that activate the scapula, they dictate the position of the scapula. So if they're not functional, then the scapula is going to be off. And if the scapula is off, the humerus is off. And that's why, and that's really what the humerus is depending on for its position, is that position of the scapula. And that's why a lot of shoulder rehab, a lot of shoulder therapy is actually going to focus on the scapula and not on the humerus, okay? Because it's really the scapula that dictates that position. So getting back to what I said there was a lot of space in this joint capsule. So we talked about arthrokinematics and the role in the slide. So we already kind of mentioned this, but when you have bringing your arm up overhead, right? You have the convex moving on the concave, so it's going to roll in one direction and slide in the opposite direction. In the shoulder, this movement is particularly important, okay? Because what will happen is if you don't have that slide with the roll, this humeral head is going to ride up. And in fact, at just 22 degrees, so just barely moving your arm out to the side, if it doesn't have that slide down, it's going to hit right in here and cause dysfunction. So you have the arthrokinematics of the shoulder are really, really key for normal function. Okay, if you don't have that corresponding slide with the roll, it's going to ride up and it's going to hurt right away, and that's a common problem in shoulder dysfunction and in treatment. Some stability is provided in large part by the rotator cuff. Again, I'm not going to talk about muscles now, but the tendons of the rotator cuff actually blend into the joint capsule in a way that's unique to the shoulder and help provide some extra stability. So again, stability at this glenohumeral joint occurs primarily through positioning, that is the proper position of the scapula, and then overall muscle control. Okay, it's fundamentally a pretty unstable joint, which allows for the great mobility that it has. The other thing I want to mention is something called scapulohumeral rhythm. Okay, so when you bring your arm up overhead, Okay, this is about 180 degrees, right, coming from down here up to here. Of that 180 degrees, about 120 comes from the glenohumeral joint. So again, the part you think of when you say your shoulder, that's only 120 degrees. The other 60 degrees is going to come from the AC joint and the ST joint. Okay, they each contribute about 30 degrees to that movement. Okay, so in the first 90 degrees, okay, so coming from here to here, you get about 25, so about 25 from here, from the ST joint, and about 5 degrees from the AC joint. In the second 90, it switches, and you get about 5 degrees from the ST joint and about 25 degrees from the AC joint. Okay. In Newman, he gives a little bit more detail in the second edition, and the numbers are slightly different because measurement, especially at the AC joint, is quite difficult. But those are numbers that are generally accepted by most people. For sure, it's 30 and 30 and 120. So 120 from the glenohumeral joint, 30 overall from the SC, and 30 overall from the AC. And again, that first 90, there's about 25 from the SC and about 5 from the AC, and then that second 90, it switches. So about 5 from the SC and about 25 from the AC. And so in the next video, I'll talk more about the muscle control of the shoulder. But the important thing to remember is that it's fundamentally an unstable joint, that you have this relationship here, which is not fundamentally stable. There's a lot of room to move, and it's why the arthrokinematics and the movement of the humeral head are so important and such a big focus in therapy.